Oncology, NCI, Cairo University, who will represent the opposite opinion for rectal cancer with synchronous metastasis, rectal first.
Thank you, Mr. Chairman. My professor and colleague, after Bismillah ar-Rahman ar-Rahim, I'd like to thank the organizing committee for inviting me to share this nice debate, as I said. I'd like to do my best in the next 15 minutes to try to convince you to go to the other side, against what Dr. Ola mentioned before. So bowel first may be the first proper way for cure. All of us know that about 1/4 of patients with metastatic colorectal cancer present with synchronous liver metastasis, and all of us know that this carry a very bad prognosis. While during the course of the disease for early stages colorectal cancer, another 50% of those patients will develop liver metastasis later on. 1/3 of patients with either synchronous or metachronous liver metastasis, they have only liver-only metastasis. So we have to focus on this group of patients. And all of us know also that the current treatment is a surgical treatment, which is the treatment of choice because it has been proven to be the only curative way for such patients. This can be achieved through combination of the advances in the systemic treatment associated also with targeted treatment, combined also with the recent technique in the surgical management for liver metastasis. All of us know that there is a new paradigm shift for the selection criteria for patients with liver metastasis. The old or the previous criteria focusing on the number and location of liver metastasis, but nowadays they shifted to focus on the size of the liver metastasis as well as the size and the liver remnants after liver resection. So, when we consider patients with synchronous colorectal metastasis to the liver, we have to check certain points. The first one, what is the type of the primary? It is very important. Is it the colon or the rectum? Why? Because all of us know that there is a big difference in the local treatment, and all the surgeons know this, between colon and rectum. And the rate of complication for the rectum is local failure is higher than that for colon cancer. The other point is what the type of metastasis. Is it metachronous metastasis or synchronous liver metastasis? Why? Because in the synchronous liver metastasis, if we look here, we have only the one target only, which is the liver metastasis, and we have two tools of treatment, which is the systemic treatment and also the resection. So whatever you start with, it is not a big deal. The problem came with the synchronous liver metastasis because of what? We have the liver metastasis, also we have the intact primary. What are the treatment tools we have here is the systemic treatment. We can go through surgery of the primary. We also have to resect the liver and make and complicate the problem also if you have a primary rectum, by the way, and we need for concomitant chemoradiotherapy. So we have to target and 4 treatment tools. So what is the proper sequence to use and to follow? This is the classic approach and was used previously by a lot of surgeons and especially the United States surgeon. The sequence starts with, as Dr. Ola elegantly presented, by the surgery of the primary first, and if the primary is the rectum, we have to give concomitant chemoradio, followed by systemic treatment, then ended by resection of the liver. The rationale behind this approach is very convincing, at first at least, because they thought that leaving an intact primary may cause future complication, which may cause complication and difficult to be treated during the treatment course. The other point, if we start with surgery of the primary and the time between the surgery of the primary and the resection of liver metastasis will allow for any undetectable metastasis to appear, so we can spare some patient the major complication of unneeded liver surgery. Very convincing approach at first. But on the other side, there is a recent approach, as Dr. Ola mentioned before, which is the liver first approach. The supporter for this approach criticized the previous one because they said that upfront primary surgery and the prolonged course of concomitant chemoradiotherapy, adding for this the time waited to give before surgery and the complication also associated with surgery will delay starting chemotherapy, and for this period we can lose the chance for curing certain patients. Also, they mentioned that the previously reported rate of complication of primary colon or rectum was overestimated, and if there is any complication from the primary, it can be managed without complication. At last, they informed that if we give chemotherapy first, okay, the primary will benefit also like the metastasis, so no fear from the primary. For this reason, they give this sequence. Look, first, they give chemotherapy with targeted treatment and go first for the resection of the liver metastasis, then concomitant chemoradiotherapy, and end by resection of the primary. Very good rationale of treatment, I think so. But everybody of us has his rationale. Where is the evidence? We have to look for the evidence. So, this approach in the recent year were discussed widely between the hepatobiliary surgeon, and we still, up till now, discuss this approach, which sequence we start first. So we have to look for the evidence behind this approach. And if we went through the literature, we found a lot of systematic review which was looking forward to better define the safety and the efficacy of such approach. And one of these systematic review reached to some conclusion, and which they did not found or did not identify any meta-analyses or randomized controlled trial that can support this new approach. The other point, they found only 4 studies that specifically addressed this new approach, which is the liver, and unfortunately they found this approach, this study, either observational study, which carry a level 4 evidence, or retrospective one, which, by the way, carry a level 3 evidence. All of these 4 studies collectively included only 120 patients. When the systematic analysis or review goes through the selection criteria, they found that every study had a selection criteria, but none of these studies used the same selection criteria. So we are faced with a non-uniform approach with a heterogeneous selection criteria. And later and further, only one of these studies are exclusively including patients with rectal cancer, while the rest of the study including mixture between colon and rectal. And all of us, as mentioned before, there is difference in local failure between rectum and colon. So, what is about if we look to this table, this is the 4 study mentioned about this, and as we see here, all the 4 studies carrying small series, carrying a small number of patients. One study only, which is exclusively including patients with rectal cancer. All of these studies are retrospective or observational. If we look at the first one, Dr. Menta and his colleague, the one who first supported this approach, will find that he included patients with advanced hepatic metastasis, and none of his patients has symptoms of the primary at the beginning of the approach. So we are faced here with some sort of selection bias. What is the complication? After the first resection of the liver, we found that about 20% of patients has perioperative or postoperative morbidity, and we faced with one perioperative mortality after the first stage, which is resection of the liver. Also, in the study, they found that 5% of the patients developed complication of the primary that mandate emergent surgery. But the good news is that no mortality with dealing with this complication. Unfortunately, disease progression during the protocol period occurred in about 20% of patients. This led to that about 1/4 of patients in this approach couldn't go through the next step, which removing the primary. So only successful in 3/4 of patients. As regards the efficacy, the recurrence rate in this study at all reached up to 50%. And if we analyze the survival outcome between the four studies, unfortunately we found that the study has a wide range of survival outcome. And the median overall survival ranged from 19 to 50 months, and also the 5-year overall survival after completing the whole approach, ranging from 31 to about 90. So I don't know whether this approach associated with short survival or overall survival. Very heterogeneous results. At the end of this review, they reached to a conclusion that the outcome between both this approach and the classic one are comparable. So we return to the start point again because we didn't achieve a step forward. Again, if anybody delivered you any information, please interpret this cautiously. If anybody informed you if you have a prolonged course of radiation treatment and you will wait then to do the primary, so we will delay the treatment, please inform him I have a short course of radiotherapy 5x5 and I can do surgery after it. Okay, complication of removing the primary may delay starting treatment. Oh, the liver surgery is a safe procedure. All of us know that liver surgery is a major procedure and only specific surgeons who are specified to this approach and may associate it with a lot of complications. The chemotherapy also, may affect the liver, steatohepatitis and sinusoidal injury. Okay? The target therapy also may affect the primary and we may face perforation with the primary when used bevacizumab. Some evidence for this approach, which is the liver first approach, saying that resection of the primary may increase the liver tumor aggressiveness in vitro study. On the other hand, there is some in vivo trials or in vivo results that resection of the primary may significantly prolong the overall survival, although it is retrospective, but still in vivo results. So, what is the perfect sequence we can use? Unfortunately, the timing and sequence of therapeutic intervention in patients presenting with synchronous liver metastasis has not been clearly defined till now. And the decision whether to go to the bowel first or the liver first or even simultaneously still remain controversial. So, let's revise ourselves again, and this is the classic approach. For now, we specify patients with rectal cancer with liver metastasis. Start with concomitant chemoradio, resection of the primary, then go for chemotherapy, then resection of the liver metastasis. This is the classic approach mentioned before. And this debated by the next one, which is the liver first approach. We have to give chemotherapy first, then to go for the liver, concomitant chemoradio, and by the primary. I'd like to look to be fair. Is this a fair comparison? I think this is not a liver first approach. I think this is chemotherapy first approach. And if we have to give comparison, we have to put chemotherapy here before. The problem not with this. Sorry. For this reason, I disagree with the classic approach. and with me also the NCCN guidelines as elegantly presented Dr. Ola before, because this is not a good approach nowadays, it's a classic one. And if we have to look for another approach, we have to give chemotherapy first, then to give concomitant chemoradiation, then to do resection of the primary, and end by the resection of the liver metastasis. From this point, this is a fair comparison, and from this point we can start the debate and we can start talking. But which is good? If we look to the ESMO guidelines, we can look here, any patient who ESMO guidelines give treatment algorithm for patient with synchronous liver metastasis who expected to have an R0 resection. Look here, they started by systemic treatment first, here or here, then focus on the local treatment because this is rectal cancer. It will be associated with local symptoms. So they did not start with surgery and did not start with liver. They give chemotherapy first, then give concomitant chemoradiation. Later on, they sent the patient for resection, and they did not specify here whether to start with the liver or the rectum. Why they did this? Because if I have patient with this primary associated with this metastatic lesion, I'll manage this patient completely different than patient with this primary and this liver metastasis. In the first one, I think that resection first approach after chemotherapy is good, but here a lot of attention should be paid for the liver because the problem may come from the liver here. So the clinical situation is the only judgment after giving chemotherapy. Don't forget this. But what if I have the same chances or equal chances for choosing one of both sequences? In this, I prefer to go to the bowel first after receiving chemotherapy. Why? Because I mentioned before, it gives us more time to assess the aggressiveness of the disease and to assess the appearance of any metastatic disease, because patients with good biology can go for resection, while those with very aggressive disease and newly developed lesion can spare more major surgery. The other one, if we resect the liver, the remnant of the liver may not, or the remnant of the liver may not tolerate further chemotherapy. The other one, if I have after chemotherapy 2 lesions, if the liver progressed, it rarely causes a complication, but if the rectum progressed, it definitely will lead to a complication. And from the previous systematic review and other one, we found that the level of evidence for superiority of the what is mentioned by liver first approach is still weak. I'm not here to recommend against liver first approach. I'm totally agree with Dr. Ola that this is good, but for certain selected patients. Who is those patients? Are those who has asymptomatic primary and advanced liver metastasis. So, to conclude, the upfront resection of the primary tumor is no more recommended except if this presented with complication. The study addressing the liver first approach was retrospective and observational, and up till now provided no evidence for superiority, and we should offer this approach for patients with advanced hepatic metastasis and asymptomatic primary. On the other hand, the rectum first approach may be suitable for certain type of patients, those with advanced primary and symptomatizing. And until we have this randomized clinical trial that compare both approaches together, we should make the decision based in a multidisciplinary team, taking into consideration the availability of effective chemo-targeted agent, the response to treatment for the primary and metastasis and also the facilities in our treating center, and of course, the skills of our surgeon. Thank you for your attention.
Thanks, Dr. Salim, for your very kind presentation and your debate with Dr. Ola about the priority of treatment in metastatic colorectal cancer. And now I think we have 30 minutes delay, so any questions for our speakers today? Few questions, yes? No time for more debate. Dr. Yasser?
Excuse me. I have two questions for Professor Dr. Ola Khurshid. Please. Do you have any explanation? You mentioned here in your presentation, you didn't segregate between colon and rectum as Salim said. Anyway, you started to say that perioperative chemotherapy, surgery, chemotherapy, according to the data of Norlange of Ambroise Paré, was positive. Do you have any explanation why the addition of the cetuximab to the perioperative chemotherapy was detrimental in the new EPOCH trial? No, chemotherapy, surgery?
No, you're talking about adjuvant. In the adjuvant setting, yes, it was detrimental. We don't have any evidence that they can use it in the adjuvant setting. But in the new adjuvant...
The new EPOCH is the addition of chemotherapy to perioperative
conversion treatment. We're talking about the conversion treatment.
It was negative and detrimental. Do you have any explanation?
You have an R0 resection of 40%.
In the new EPOCH?
Pardon?
The new EPOCH, data of the new EPOCH trial, the perioperative chemotherapy. There is a statement ومهمة. Don't give chemotherapy or target therapy for the perioperative chemotherapy and not neoadjuvant chemotherapy.
Yes. Don't give it after surgery.
I'm confused what to give.
Let's categorize this. Perioperative is before surgery, then you do surgery, and then you go after surgery. Before surgery, of course, you give your best regimen that will give you the best results. After surgery, no, we don't have any data that we should give targeted agents after going the surgery, because it's more of an adjuvant treatment. So you are right in this, but don't give the targeted treatment after the
definitely sure, whether Avastin or bevacizumab or anti-GFR, there is no place for this or that in the adjuvant setting. The second question, please, because I'm become more confused in the treatment algorithm of metastatic colorectal cancer first line. According to the data you presented, I should not prescribe bevacizumab in RAS.
No, you should prescribe it a second line.
I have not to prescribe bevacizumab against all guidelines and all rules as first line. You mean that the NCC guideline is out of order, definitely, because the first line is ومش كاتب لك بين قوسين in the mutant if you follow the guidelines in the ASCO and the SCN and the Barcelona even data. So if I follow the data دي يبقى I'm definitely doing a harm to my patient as first line bevacizumab in metastatic colorectal cancer.
The answer is yes, you are. I'm doing harm. You are not harming him, but you are.
It is contraindicated.
You are not giving him the treatment that will achieve your R0 resection, the best response rate, and the best overall survival.
So if I have a patient with no R0 resection, irresectable, never irresectable, never to give first line Avastin. This is the state of art until to reach here. Irresectable.
Yes, if it's irresectable, you can give it for your RAS mutant patients, and you can give it as second line, and this is the standard of care that everyone is doing.
This is written in the guidelines.
It's in the guidelines that you can use either this one or that. But if you go meticulously in every trial and try to get the data about the responses and the overall survival,
I went into details, definitely.
Yes, of course.
Sure. But the statement here, عشان the closing remarks, what I followed in the presentation that I had never to give first line bevacizumab in metastatic CRC, which is written in 4 guidelines. If you have guidelines, new guidelines in this conference, we have to move. And to omit the anti-angiogenic approach in metastatic colorectal cancer as first line. The data we have, the anti-EGFR in second and third line monotherapy.
Dr. Yasir, this is only in patients who are KRAS wild. KRAS wild are a special situation of
RAS,
patients.
not KRAS, RAS.
In the RAS, the pan-RAS, yes. As you know, of course, yeah. So these are a special group of patients.
In the RAS wild patient, I have not to give.
If you can give an anti-EGFR, that will be better for the patients, as you saw, and as
better
you know.
for the patient who is willing to do surgery.
Yes, of course.
Overall.
And overall, if you're looking for overall survival, the only one that gave you an overall survival is the best sequence, and the best sequence
The overall
is
survival is better when using in RAS wild. The overall survival is significantly better when using anti-EGFR.
Anti-EGFR
As first
followed
line.
by bevacizumab. Yes, thank you.
In what trial?
In the FIRE3 trial.
The FIRE3 trial is negative trial.
Only
The
an overall
primary endpoint
response.
was not the overall survival يا اخوان. خلاص ندي بلاش ندي.
Biological point of view, you have the choice. You have the choice of giving يعني RAS, BIVA, or RAS anti-EGFR. But you have to evaluate the morbidity, the comorbidity, and the side effects that may affect the patient for giving either or regimen.
According to the results, or according to the recommendation in KRAS, while we use EGFR inhibitors, لكن في mutant type we have the choice to give bevacizumab. الوايلد تايب احنا بنبتدي بالسيتوكسيماب.
I think both are equal, and we have to choose one of two based on many different criteria: the clinical situation, toxicity criteria. Patient with hypertension cannot receive BIVA. Any patient with media show cannot receive EGFR due to rash. So it's many factors. Dr. Mustafa Al-Haddad.
Just away from the BIVA EGFR battle, I think things is not as simple as it was described, because there is a lot of other issues we have to take it into consideration when you are talking about rectal cancer patient. You are talking about patient with sphincter preservation, without sphincter preservation. This is a very important issue, because sometimes you may even exclude radiation and you can just push with chemotherapy, because your patient has nothing to do with the sphincter down there. I mean, you don't have to add radiation for the rectal patients. The second point also, we have a lot of data nowadays talking about 5-FU combined with Erbitox, 5-FU combined with oxaliplatin, and if you looked at the cumulative dose with the weekly oxaliplatin given, I think this is a very effective systemic treatment. So I mean, it's not that easy giving just chemo first or radiotherapy first or delay. I mean, life is more complicated, and I like the approach of Dr. Salim saying that it depends mainly on the clinical situation that you have. Thank you.